And we are live today. Brad and I are joined by Dr. Mike Stair. Mike is a fellowship-trained physical therapist, a physical therapy educator, a personal trainer, and a nutritionist, all in the Boston area. He is also the owner of Orthopedics Plus Physical Therapy and Spectrum Fitness Consulting. Did I get all that?
Right. You got it all.
So now I have two doctors. Brad Dieter, PhD extraordinaire, is right there. Dr. Mike Stair, and then Lonely Jay is right here. And that's about it. That's all I got. So how are you today, Mike? Thanks for coming on.
I'm awesome. I'm doing great. How about you guys?
Darn near perfect.
Good.
I think it's been almost about a year since we met in Toronto.
Mm-hmm.
It was, It was at the cookie off, right?
Yeah.
Wow, after copious amounts of food too. That's probably about 30 pounds heavier.
Yeah, it's crazy that was a year ago.
I can't believe that. Holy cow!
Yep.
Wow, we've been working on projects together and been come a long way. Started projects, stopped, came back to it. Been a long roundabout. So we got some viewers already who are just interested in Mike. And Mike, I think Brad laughs at me because every time your last name is Stair, it's not a hard one, but I think I've gone with Mike Strong, Mike Strange, Mike Storm. and it's not like I don't talk to you every single week while we're working on things.
Right.
It's I think I go, Mike, what the hell? Mike S. You know who I'm talking about.
Well, I totally get it, Mr. Woith. I mean, sometimes that happens.
Exactly. Worth is the number one thing that people come up. My favorite is when they call me. I'll call them. Okay, Frank. I get that all the time. Frank. No, Jay. No, okay.
You look like a Frank.
Yeah, I don't like on the phone. So, all right. Well, while everybody's coming in, if you guys have questions for any of us, feel free to ask them, but we will jump right in. So our first thing we're going to talk about, and since we have Mike, a physical therapist with us, we'll talk about some injuries. So let's go over injury prevention. So Mike, if you had to pick a blanket statement, we'll just see where the conversation goes from there, a blanket statement for everybody, the number one thing that people can do on a daily basis to prevent injury during exercise.
Okay. So injury during exercise, I would probably say the first thing is look at your logs and take a log, because I find that one of the most common reasons why people get hurt is volume or load progression is too great. Very rarely is it one exercise I see. Very rarely is it a certain style or type of training. It's simply when they have rapidly changed from where they previously were to what they're currently doing now. So load management, volume management. A very basic rule of thumb I give people is that if you increase things by about more than 10% in a week, your likelihood of seeing an injury coming about is going to be pretty high.
Okay, I like that, the 10% rule. That's a good one.
So how do you try to help people quantify that load, right? I think a lot of us, myself included, most of the time just kind of go to the gym and work out and don't really track our load. So what are some things that people can do that are not like overly intensive to like start having an idea of what are they doing in the workout? Like what is that load?
Yeah, I like two methods. My favorite one is just the RPE, rate of perceived exertion. The reason why, quantifying it with, exact loads is because people are using different implements. Sometimes they're using weights, sometimes cables, sometimes bands. But pretty much everybody could rate the intensity or the difficulty of the load on a 0 to 10 scale. So if they've been at an RPE of, let's say 6 or 5 or so, and then they're maxing out and they're going to be at a 10 or so. So that's one. And I think the other that I like, although I think it's a little bit more difficult unless you've had several weeks, if not months of experience, is the reps in reserve. So, if you finish a set and you said, I probably had about 3 or 4 more in, and then you all of a sudden switch and say, I read this article on, failure training, and I'm going to do 5 sets to failure. That's obviously a recipe for disaster. You have a rest in reserve is 0. So those are two of my favorite. But then some obvious ones, number of sets, and then the simple multiplication, sets times reps.
Fair enough. I like that. Just volume, and the RPE scale is something I think that's not controversial, right? When to implement it. A lot of times, especially people new to lifting, and they can't implement the RPE skill because they don't know what their exertion actually is. Do you think that most injuries? Do you see that most injuries from weightlifting or sports come from the beginner in the activity, from the intermediate, or the advanced person in that sport or activity?
I think a lot of it comes from people not recognizing the distinction between the pain of injury and the strain of effort.
Oh,
and
my questions to ask you. I have like the exact same verbatim. Oh.
And that's hard. And I think a lot of it is psychological. I think there's a certain type of person who thrives on hard work, and part of their success is based on not stopping when things become uncertain or difficult. So those are the people that I think are more advanced, and they look at pain as something that they can work through, that they can push through. So they're probably the ones that are getting hurt from too much intensity. I think it's the inexperienced people that are getting hurt from, they get excited and they see a new shiny object, and they look at somebody doing some cleans and some overhead snatches and say, that looks awesome. I'm going to switch to that, and I'm going to follow that program. And they're jumping around to different programs, and so it's hard for them to gauge the intensity, the volume, and the discomfort they're getting. So I think it depends on the situation, of course, but who was that chiming in there?
My cat.
Nice. I wasn't sure if that was Brad or something.
It was.
But,
I'm known to make those types of noises at times.
Right. I wasn't sure if that was an approval, or not.
Not like that you said that you were talking bad about people who like to clean and jerk. That's his favorite exercise. So.
Okay. Yeah, that's what I figured. So
sorry about that.
So what are some of the most common injuries that you see that are easily preventable?
I think the most common are shoulder problems. The reason being is that there's so much mechanics involved in it, and there's so many opportunities to change existing exercises. For example, let's say you're doing squats. A lot of people that have instability in their shoulder or lack of range of motion will look to, well, maybe it has something to do with my pressing. Maybe it has something to do with my shoulder exercises. But a lot of times I see their shoulders getting jacked up because they're being pinned in external rotation that they don't have any business being there. They don't have that range of motion, and you're pinning it there behind a bar. Simple technique things, simple tweaks. You can keep people with shoulder pain in the game, usually by making simple habit or tweaks in positions. So it's super common. I mean, I don't know anyone that's older than 35 that doesn't have a bad shoulder, that lifts. Everyone does. I used to bench this, but then my bad shoulder. Or I can't do X exercise because of that.
My elbow.
Yeah. So I think that's where when I see somebody come into the clinic hurt from working out, that's where I get really excited, because they're thinking, oh, I got to take 3 months off. I'm like, no. We can make some simple tweaks here. That's probably the biggest one. Next are back issues. And the reason why I think the back ones are easier to fix is because a lot of them aren't being hurt in the gym. A lot of them are getting hurt in their day-to-day life, in their ergonomics, and how their, what I call spine hygiene is taking place. And many times they're looking to change what they're doing in the gym. And oftentimes I start what they're doing outside of the gym. So those are two of the ones I think I have the most success with.
I like that. That everybody has a shoulder injury. I mean, because it's true. Every single person that I know over 35 has it's my bad shoulder. And that actually leads on to one of my questions that I had is, with these old, I have that old injury from 20 years ago, that, my old football injury.
Yeah.
Is it possible to get over that? Do they actually still have that? Do you find that most people actually still have that injury, or they're just afraid of re-injuring it? And if they do have that injury, is it possible after like a 20-year-old injury to rehab it and move past it?
Yeah, that's a fascinating topic for me, because that's how I got into this whole world, from accumulating massive amount of injuries from 20 and 25 years ago. So I'm definitely living proof of it. I tend to see a lot of that in my practice. The amount of people that I've seen that have had ruptured rotator cuffs that have been repaired, and then they successfully rehabbed it and it ruptured again, and they didn't get it repaired because either there wasn't enough tissue available, or they simply just didn't want to endure the process again and go back to bodybuilding and go back to powerlifting in their 60s, 70s. There's too many cases to count. So I can say without hesitation that yes, that is definitely possible. And one of the neat reasons why, I was just reading this article, several articles by Jill Cook, the emerging change in how we're looking at, let's say, tendon issues, for example, is very rarely do tendons actually heal. Tendons usually stay pathological even after their initial insult. But what ends up happening is the other parts of the tendon end up getting stronger and thicken. So even when there's ruptures and even when there's mechanical damage to the tissues, it seems that our tissues can adapt without quote unquote healing. That's why these MRIs look god awful in these people, yet they're able to still continue. So there's a lot of examples of that throughout the body. So I get very optimistic about that.
Yeah, no, that was probably the most optimistic, no nonsense answer I think I've ever read or heard on the topic of old injury rehab. Because I know when I was in high school, I tore my right rotator cuff, and I didn't have surgery. I went through therapy for it, and it doesn't give me problems really ever, unless when I was a fireman, it would hurt if I was crawling around a lot and had a lot of weight just on that shoulder, it would start to hurt. And I was told by many, many, many therapists that I'm just going to have to deal with it for the rest of my life. And then once I started lifting extremely, religiously, and got built up a lot more muscle, I never had issue with it again.
Yeah, and I want to clarify something that's real important. I ruptured a disc in my low back carrying spinal cord injury patients when I was in my early 20s. And the gentleman who became my mentor had a really interesting statement to me. He said, "You're never going to have a normal back, but you're going to be able to do whatever you want." And the way he's saying that was that you have to treat it differently. You can't abuse it like a healthy back, but you can still do whatever you want, provided you treat it well. And I'm in the same boat as you, Jay, with the rotator cuff. I did the same thing, tore my rotator cuff. I can't sleep on it all night. I'll wake up with a dead arm.
Yep.
I can't, grab something in the back of my car seat and yank it over the top of it. It'll flare it up. But if I treat it well and I exercise frequently, I can still play in softball leagues and still, do overhead lifts and the things I want to do. So I think you have to respect the anatomy. It's not that anatomy doesn't matter and these changes aren't significant. It's just that you have to treat yourself a little bit better than you otherwise would had you not had those injuries.
Agreed. That's interesting. It's nice to know though that I'm not alone with the random rotator cuff pain. That's kind of a thing that you always wonder if, am I just broken? Is it permanent? Is this normal? And I like your perspective of I'm still able to do it. I just have to it's I can do it without pain. I can live without pain. I just have to modify, but I'm fully able and capable, and I don't have limitations. There's just things that cause some discomfort sometimes.
Yeah.
So how much, in your experience, because I asked this question a little bit selfishly, is how much of the recovery from kind of a long-term injury to kind of normal function is mental versus physical?
I would say it is at least 70% mental.
Okay.
It's huge. From the positive and the negative, your mental outlook on that, you could be your own worst enemy, and you can be impatient, and you can be thick-headed, and or you could be on the other side fearful and fatalistic and apprehensive. Both are pretty difficult challenges.
Mm-hmm.
I think that's probably where, when you hear therapists talk, it's where they talk about the art and the science. Yeah. The art is recognizing that part and having the way to convince somebody that, yes, you can load it. Yeah, your tissues will adapt. No, it won't be better in 3 weeks. No, you can't stop after 6 months. So I think it's a huge, huge part. And I think that's the part, if I could go back 20 years ago, I would have spent more time learning. Rather than pounding the biomechanics. Not to say it's not vital, but it's a huge part, man.
So building on Brad's question, I want to jump into the next topic, which is injury recovery. And again, we'll just see where I mean, this has been a great conversation. We've hit all the points that I had written down to keep us moving. So let's start with like, this is a conversation you and I have had, and one of the project we've been working on. When is enough rehab? I mean, obviously a therapist will tell you, oh, you have a rotator cuff injury. It's 16 weeks. Here's your program. Or your insurance says I'm paying for 24 weeks and you're magically healed at 24 weeks. When does a person know that I'm good? I don't need direct rehab on this specific injury anymore.
That is an awesome question, and I think it's a little bit complicated because we do exist within those constraints, as you just mentioned, insurance. When does rehab end and when does therapy begin? I look at it as a continuum. Rehab really never ends. When I discharge a patient, I tell them my job was to get you to the starting line. I didn't bring you to the finish line. I'm getting you to the point where you can now do this independently. And what makes people feel empowered enough to be independent and self-managing that, that could be 3 days for some people, it could be, years for others. So I really look at it as, to what extent can somebody figure out the difference between the strain that causes or facilitates adaptation and healing versus the pain that causes injury. They know how to, I use a football analogy, they're able to know how to call an audible. They got a game plan and they can get the line of scrimmage, but when variables change, how do they quickly adapt? Are they competent at doing that? Do they know how to progress and regress the routine? Some people, I don't think, ever get to that point, and they always will need guidance. Other people will get there very swiftly. So I don't really think it has to do with any physiological marker. I don't think it has to do with any external outcome. I think it more has to do with the individual's behavior and the type of support that they need.
Okay, perfect. That was these are like the most enlightening questions we've ever had on this show, Brad. Normally we just talk about astronaut nutrition. This is
and by the way, I wish I could tell you, about 24 weeks. That's when you're all set.
Yeah.
But unfortunately, it doesn't fit in that.
No, but what you're saying isn't even like, oh man, it's just like, oh, it's not like a disappointing, like there's no answer. It's like a realistic, that makes sense to me. I get it. Like you're putting it into realistic words that I get it. So kind of good. So with injury recovery, when I'm in rehab, we a lot of people out there, I might tear my rotator cuff, or maybe a common one we see is people with hand injuries. Can I still lift? Let's say I tore my rotator cuff, or we had a client once who tore their pec.
Yeah.
Can I still lift other body parts while I'm rehabbing? So if I have an upper injury, am I good to lift lower? Am I good to lift? If I have a right side injury, am I good to lift left side?
Oh, absolutely. For two main, very clear factors. Number one is, you mentioned the psychological part of this. When people get injured, they're crushed. And it's not because of the pain. I mean, that's part of it, but that's relatively momentary. It's the realization of their vulnerability. It's the catastrophification of, oh my God, I'm getting old. Now I can't do this. I can't do that. It's the realization of all the inconveniences. Life's hard enough. Now they got to figure out how to do this and that without an arm or a leg that they used to using. So mentally, the biggest thing I can do to help somebody acutely is show them all the things they can do. Because for the last 24 hours, maybe even longer, people have been telling them what they can't do. Don't do this, don't do that, don't do this. And then they finally meet somebody like, hey, let's look at all the stuff you can do. And their mind hadn't even gone there. So that is huge psychologically. Physiologically, there was really good research, and I'm blanking on the term. I think it might be called a bilateral effect. But in essence, they looked at people who had fractured arms. One group was advised not to use their unfractured, uninvolved arm, with exercise. The other group with the fractured arm was asked to do weight training with their uninvolved arm. When they got out of their cast, the group that had been doing weight training with their uninvolved arm, the involved arm came out of the cast relative to the other people stronger. And they think it had something to do with the neurological connections that were facilitated during that process. So Yeah, you can actually help the healing of it. It was previously thought you don't want to cause a muscle imbalance. But I strongly encourage people to strengthen the other limb, strengthen the uninvolved tissues, of course, not only for the psychological benefits, but definitely for the rehab benefits.
So, Brad, if you have a question, feel free to chime in. I have two more that I wanted to get to.
No, but what he's mentioning is really interesting because we see that a lot, especially in like the EMG literature. There's definitely that crossover effect on each side, and so it's very interesting that you can train one side of your body and actually see some neurological and musculoskeletal adaptations on the other side.
Yeah, no, I think that's crazy that it happens. I remember reading that study too, and I can't remember where I read it. It was part of the ISSN diploma program, and I can't remember all of it. But yeah, no, I'm gonna have to look that up again because that's an interesting one. The two questions: one, we don't have to expand too much on it; just really touch base.
Sure.
Are there, everything I have read, and I think Brad and I have had this conversation too. Everything I've read is, when you're recovering from injury, you could be in a slight caloric surplus with higher protein intake. Is there anything outside of that you recommend, or do you not agree with that statement?
No, I've heard that your caloric needs can rise by up to, after post-surgical, is where I've seen most of the research, by up to 20%. I believe doesn't Lyle have an entire book on that, McDonald? I haven't checked it out, but I've seen some of the research that he referenced on it, and the most definitive I can find is post-operative for like a total hip replacement, a trauma. For at least, I think it was about 4 to 6 weeks, it was elevated.
Yeah, and John Bernardi and Lyle McDonald agreed on a subject, so I figured that subject had to actually be true when they both like had the exact same. I mean, I think John actually referenced Lyle in that, so I was like, wow, they must actually agree in something, so it must be true. So I just want to see if there's any caveat, but perfect. And then the last question I have for injury recovery before we go into re-injury prevention, actually after this question, we'll get to some of our questions and then hit our last point. When I'm, you see these athletes who have, and obviously the money that is spent on them goes a long way, and genetics in them plays a huge role, I think. But you see these athletes who have ACL tears and they're out for, 8 months, a year, but they come back and not only do they perform where they were, they perform better than they did very often. Obviously, with Tommy John surgery, it's not always the case. It's not always the case with everyone, but you do see it fairly often, especially I'm a big hockey fan, used to be, and you see it a lot in hockey players. They get knocked down, they have surgery, they come back 10 times better. So for the average person who doesn't have 12 hours a day getting paid to train to get back to where you were, is it possible and realistic to get back to where you were physique and strength wise prior to your injury? Is that a realistic expectation?
It really does depend on the type of injury. When it's a Achilles, when it's a tendon, the elasticity of the tendon is permanently damaged after you have that. We still see people going back to play basketball, to jump, but I have not seen any research to show that they can jump as high, they can run as fast. I ruptured my patella tendon. I can definitely feel the difference there. As far as physique, though, I haven't seen any indication that wouldn't change. You can't get the same amount of hypertrophy. When it's a ligament, though, the recoveries for that are phenomenal. What people have been able to do from that are great. I believe, however, as you're mentioning, the athletes after coming back after 8, 9 months, that is very, very rare in the general population. The re-injury rates are very high. This accelerated rehab is starting to get a little bit of some backlash. People are saying that it shouldn't be beyond a year now, or before a year. Okay. I think the jury is still out on that.
I'm thinking of Derrick Rose.
I know. I'm a Bulls fan too. That kills me.
And that guy just has so many. I can't imagine what problems he's going to have later on in life.
Yeah, that's pretty clear. We know that when you have an ACL injury when you're younger, you're going to have premature arthritis.
Yeah. Perfect.
Well, it has been interesting to see how long and how patient they're being with KD's Achilles.
Yeah, exactly.
With who?
Kevin Durant.
Oh, yeah, I'm not a basketball person, so I have no
What?
idea. Yeah, no idea. So, we have a couple questions here, and then we'll jump on to our last topic. I think that child disappeared into the abyss that is his bedroom. So let's see. Abigail Minks. I hurt my right knee 6 to 7 years ago in jiu-jitsu. It healed and no longer causes me any pain, but I still have a lot of instability and balance issues on that side, as well as difficulty engaging that quad as well on the left. Is there any hope that eventually it might get better? I've only been lifting for 3-ish years.
Yeah, totally. Again, seeing this a lot with myself, with other folks too. One thing that I find very consistent, people have had injuries like yours, Abigail, is with the instability, is proprioception goes out the window. One example of this is try standing on one leg and concurrently turn your head back and forth, or shut your eyes. When the visual field isn't there to compensate, your proprioceptive system is exposed. And I find that many people rarely fully get proprioceptive function back until they challenge it in one of those two circumstances. The other thing is people are remarkable, especially athletes, at compensating. So I find putting yourself in positions where you can't compensate. So single leg squats, lunges, step ups, single leg deadlift. It's amazing how your other leg will hide your weakness on your involved leg. So yeah, I think even if it's been 3 years, if it's been 6 years, I think that's not a time frame that's too long. Admittedly, it does get harder though as time goes on.
Yeah, and Abby is actually one of our moderators in our group. So for our project, we might have to contact Abby for some things.
Oh yeah, absolutely.
One of the questions I'm following up on Abby's and what you said, kind of interesting, and maybe it's way off any topic. Have you guys ever heard of the amputees who have on their hand and they have a lot of pain, like wherever the amputation is? So they put them in a mirror box with the other hand.
Yes.
That to me is the most fascinating. Is that based on the similar thing of what you're talking about, kind of similar structure?
Not as much on the proprioceptive thing. That is more on the perceptual issues. That's more on the sensory cortex, and the mapping of the sensory cortex gets smudged. A very crass example of that would be like if you're trying to scratch your back and somebody's down here by your side, and then you keep saying, no, it's up further. Next thing you know, they're up on your right, scapula. Like your body's ability to map it gets all smudged and screwed up.
Yeah.
So that's a different scenario. But not completely unrelated. I mean, those can also be issues of pain.
Yeah. Interesting. Brad, did you have something?
Well, no, I was just going to ask, so you kind of mentioned how we're master compensators, and would you say that our bodies generally kind of take the path of least resistance? Like we find the most mechanically efficient way to do things, the least painful way to do things, the most efficient way to do things. And so even if it ingrains kind of long-term bad motor behaviors, we kind of default to that state.
Yeah. And I mean, depending on the context, it may not even be bad motor behaviors. One of the biggest errors that has been made in managing any condition has been how they dealt with cerebral palsy. Back in, even when I was a child, they used to cut their heel cords. And, you've seen people with CP walk, they have that weird gait where they walk on their toes, thinking that, well, that's aberrant. That's wrong. Let's cut their heel cords. They couldn't walk anymore. They realized that's a compensation that actually was helpful. Yeah. Evolutionarily, it would be ridiculous for a body to not compensate when we've had a blown out Achilles or a blown out ACL. However, we haven't adapted to the fact that you can replace all of that and normalize the function relatively. So, in short, I think you're exactly right. And if there's a capacity to rehab, we have to kind of trip that normal tendency of efficiency and adaptation.
There was I don't know, I've been hooked on Joe Rogan, the Joe Rogan show for the past 6 months. Like every night, that's what we watch when we go to bed. And there was one last night from his archives that I was watching, and it was about the missing link in human evolution and how we went from chimpanzees in the rainforest to walking bipedal primates. And it was really interesting to me, and and I kind of knew it, but like hearing it, like instead of going from trees where we're supposed to go like this, we stretched out and we're supposed to go like this now. And that was, I don't know, it's a little off topic, but that whole conversation that you just had reminded me of that. And I thought, So, Victoria said, I currently have a sore Achilles from overwalking. I think I have been icing and elevating it. Is there anything else I should do?
Yeah, comes right out of the research I was just reading from Jill Cook, and I strongly recommend you check that out, Victoria. Um, a lot of Achilles tendinopathies is what we're calling it now, and they're not calling it tendonitis anymore, because the prevalence of, or the evidence of seeing inflammatory cells in the tendon is really low. So treating it with rest and ice, with the assumption that there is a active inflammation going on, in spite of having pain, is not best practice anymore. That has changed dramatically over the last 10, 20 years. What the Achilles does respond brilliantly to is load, even if there's a certain presence of pain. In the early stages, what we found, tendons love load. The trick is finding that Goldilocks zone. Enough load so we get tendon adaptation, but not so much that we get irritation and inflammation. The simplest way to do it, if it's really irritable and angry, Victoria, is to do isometric loading. You're standing on a step with your heel over the edge. Over time, what you want to do is very slow and relatively intense. So this should feel like a 8, 9 out of 10 in terms of difficulty. Slow, steady, eccentric loading with your heel going over the edge of a step. So loading the tendon is what it needs. It's a little counterintuitive, but rest, ice, inflammation, that doesn't usually treat it very well.
Awesome. So the RICE acronym is been changed, correct?
Specifically when we're talking about tendons, and especially large, thick tendons like the patella tendon and the Achilles, it is drastically changed away from the rest and heal type of thing. Instead, it's load. And there's 2 basic parameters, by the way, with loading. I think this is important. One is load it twice a day, highly intensely, 7 days a week. The other is load it more like a traditional weight training program, 3 days a week, 3 to 4 sets, slow eccentric, prolonged holds, and then slow concentric. The compliance rates of the latter was about 96% compared to 80% with the former. Success rates were 90 to 100% depending on the research. So lower lethal dose is what I'm a big fan of, and that's what I would recommend.
Cool.
But it's a really interesting topic, and it's something that's really evolving.
Yeah, no, that is definitely interesting. And then our last question comes from Alice, and this is a torn lateral meniscus. She's done with physical therapy, but it still pops and clicks and medial pain. Should she do surgery?
The only circumstance where it's even marginally advisable to consider surgery in that case is if you are not able to extend your knee, and when you try to extend your knee, it feels like there is an actual lock. There has been, I would say, at least 2 clinical practice guidelines released by every major rheumatological or orthopedic association, and meta-analysis in the last probably 4 years that have universally found meniscal surgeries are not effective or not more effective than conservative care. So we are seeing a huge change in how we manage a meniscal issue. There is some evidence showing that with meniscal surgeries, the likelihood of further problems like arthritis is dramatically higher. So we have minimal to no benefit, and we have not an insignificant risk. So the only exception to that is, again, a locking mechanism, meaning that you can't extend your knee because it's locking. So I would strongly go against that, and the evidence on therapy in that case is very strong.
Well, all right.
And then is some of the reason that they have professional athletes, like the high profile one last year, the Zion Williamson torn meniscus, is that simply a function of return to play and the value of his contract over the short versus long-term outcome? Is that generally why those decisions are made?
I don't know why those decisions are made, to be honest, but I think the main one, to be honest, is that it's forced rest. It legitimizes, either in the player's mind or in the people managing his condition, it legitimizes the forced inability to load, both in terms of volume and intensity. They've done placebo studies.
The sham studies, yeah. So why wouldn't they just do a sham on the athlete and just Tell them they had it.
Right. There'd be some big conflicts in the manage of that, but I would love to see that surgery. That started.
All right, we have a couple more questions, but let's get to our last topic, and then we'll jump back to all of our questions. And our last one is re-injury prevention. I know this is something you and I have talked extensively about. So, if we have re-injury prevention, what is like the best long-term solution for re-injuring, like a blanket statement again, the best long-term advice you can give for somebody after they've completed rehab, they've had an injury, they've gone through rehab, they're good. But in the back of your head, it's always there that you're going to re-injure it. What's like the best tip you could give someone to prevent that from happening?
Don't stop. Don't stop, therapy. Don't stop, training. Don't stop whatever it is. A lot of these injuries are magnified under fatigue. A lot of them are due to lack of confidence, so they disproportionately load the tissue, and then when they have to load it from a sudden stop, the tissue's not prepared for it. That would be my simplest explanation: is don't stop. And I'll give you one real quick stat on this, going to extremes. Total hip replacement patients. They followed up with these patients 2 years after surgery. 80% of them were weaker 2 years after surgery than they were 6 months after surgery. And the reason being is that most therapy ends at 6 months, and they stopped it, assuming that they attained a certain level of strength that was going to stay with them.
Gotcha. That's an interesting one. So, what injuries do you think are when do you see from sports injuries? What injuries do you see people re-injuring the most?
Ankles. It's I'd say if you sprained your ankle, you got anywhere from a 25 to 50% chance of spraining it again. Hamstrings, it's a personal one for me. I've probably torn my hamstring 9 times.
What do you do to get hurt so much? You've like had every injury.
It would take up 3 of your shows for me to explain it all.
So note to self: don't work out with Mike, because not that he's going to do something wrong, but luck is against you. Apparently,
I would say don't play with Mike. Work out. I'm pretty good in a controlled environment. Once you get a ball or some type of game involved, that's where bad things happen. But those are the ones that are really hard. It's something I tell people, like, listen, you can do everything right, and your likelihood is relatively significant of having it again.
Okay, perfect. Brad, do you have any follow up on that?
I don't think so.
I guess question.
So let's say somebody has some sort of like ankle injury. How detrimental is it to rely on like external fixation, like a brace or something like that, for kind of long-term safety? Like, how much does that become like a maladaptive crutch versus actual safety mechanism?
Yeah, there have been some suggestions that patellofemoral problems increase in basketball players that primarily use a bracing. They suspect it's due to the lack of dorsiflexion. I'm not aware of any evidence that's actually proved that. Although anecdotally, I do know a lot of people that work with that population. They've seen that correlation. I don't know if it's because the acute lack of dorsiflexion or the chronic adaptation of a lack of dorsiflexion. It might be correlated with that. Looking at other areas like the spine, with bracing, or the neck with bracing, they have not found that prolonged bracing leads to weakness, leads to any disuse, leads to anything other than sometimes an inflated level of confidence. So they think that the Superman when they have a brace on their midsection. But when it comes to ankles, I say the external fixation in the absence of having fully recovered ligaments, the benefit probably outweighs the risk. So if you're playing basketball, I'd say definitely go for the bracing. Overcompensating for that would be fine, and then train outside of the brace. So competition brace, outside, go without it.
Okay. Then what I want to circle. If anybody, Brad, if you had any more questions or anybody had any,
I'm good.
Back to something you had said earlier, Mike, and that was with pain, and when we got into the RPE scale discussion.
Yeah.
And how I think one of the problems that people have, and I know I've had it personally, and I know we hear about it from our clients, and we see it in our Facebook group every day, and that is this pain, and what do I do? And so it's a couple part question. The first one is, how do you identify real pain versus discomfort?
Yeah.
Like if you had to give a tip to somebody on that.
Your brain doesn't distinguish those things, by the way.
Okay.
So there's not a very strong scientific way that you can say, well, this is how you know it's that. What I do tend to know is what correlates with tissue damage and what correlates with a willingness to train again. Usually has to do with the magnitude of the pain as rated by the person and how long it lingers. So a great rule that I've used successfully with people is that if your pain gets beyond a 5 during training and it lasts for greater than a day, you've probably started to flirt with the lines of causing damage that was either unnecessary or counterproductive. That I've found has worked very, very well. And the thing I think that works the best about it is that it's like a contract that I have with the patient. Like we have established some meaningful guidelines that we're both comfortable with. It's kind of like investment. It's like, okay, you're going to put this money down. You may lose this much. You might gain this much. What's comfortable for you? And I find that mutual agreement is probably a big source of success for a lot of folks, as opposed to having some arbitrary definition saying, no, this clearly isn't real pain, or this is tissue damage pain. I don't know where I'll ever find that, but it's worked well for me personally, I found.
Yeah, and then I like that the brain can't identify it. That's a good thing, I think, to know. And you kind of answered it. And my follow-up would be, if you had to give like somebody's, I'm asking you, I can't tell, when I lift, I have a little bit of soreness in my shoulder. I could keep going, but it's a little like pain right here. Do I don't get it every time I lift, just sometimes when I get it, should I stop for the day? Should I stop exercise completely? Should I just stop that movement? Can I do other shoulder exercises, or should I have that pain for the first time in 3 months? Should I just take a complete week off of lifting my shoulders?
I'm a huge fan of optimization versus avoidance.
Okay.
So I think pain is, and especially if it's of that magnitude where you're not making a clear, definitive, like, oh, this is really no big deal, or this really freaking hurts and I need to change something up. If it's in that, I'm not sure what I can do. That's usually where I say, well, that's an opportunity to learn. Don't just stop, put down the barbell and move on to something else. Maybe if you do a false grip, it allows a slight extra rotation, and that just a little bit extra rotation makes your tissues, for whatever reason, function in a better way. Maybe if you go at a decline a little bit versus incline, maybe you change your grip a little bit. Maybe it's a load issue. Maybe it's a range of motion. Maybe you put a foam roll or half foam roll on your chest and you stop that range of motion. It gives you the opportunity to explore and learn. Pain is good data, and it's not always a scary thing to avoid. That being said, it should be respected. You shouldn't just say, "Oh, that's just weakness leaving the body." It's good feedback. Listen to it, and maybe we'll find it out. So I don't know if that answers your issue that directly, but
it didn't just answer my question. It like knocked it out of the park. Like that was the best answer I think I've ever heard on how to I like you should respect pain. I think that's probably the best answer I've ever heard on it.
Yeah, not fear it, but respect it.
Yeah, no, I agree. All right, we have another question. 2 more questions. Amanda Hall said, lots of treadmill time lately, and I feel like I'm overcompensating with my quads and my stride is just off. Any way to activate glutes and hips prior or during to treadmill runs?
When I get these questions, I have 2 colleagues that I actually just spoke with this morning that do gait analysis, and they are the specialists in that. So I usually defer to them. So Amanda, I don't want to give you a really thorough answer, that kind of goes beyond what my main level of expertise is. I tend to defer to them because I have them. What I would tell you on that is investing in a gait analysis is great. And I would not invest in a gait analysis that's done by somebody who mostly does orthotics or shoe wear. They are looking usually from a relatively limited lens. Find a physical therapist that does that. I think that's where you're going to get the best insights, and they can use cognitive behavioral therapy So they don't look at it as just like, oh, well, this muscle's weak and this muscle's tight, so strengthen this muscle. Sometimes it's how your brain decides to, load, and you have to change how the brain decides to do an automated activity like that. So it's pretty in-depth, but there's services out there that do that, Amanda. So I would look for that, and you'll probably get far better answers from that than you can from me.
Dr. Dieter, do you have anything on quad overcompensation?
That is way far out of my depth.
Okay. I didn't want to be out of the conversation. You were looking a little out there. Just wanted to make sure.
No, I did do a lot of EMG work in my master's, but it was on cycling, not treadmill. So I really can't speak much to treadmill work.
Cardio all translates the exact same. I read it on T Nation.
Correct. Running and cycling are exactly the same.
They are. They both just make you breathe faster, and if you're on a treadmill, you don't go anywhere. Like,
Jay,
and it'll make you weak. So,
yeah.
Have you ever ridden a bike for like an hour or two and then got off to try to run?
No,
absolutely not.
It's so strange because like you get this like movement pattern of like 90 revolutions a minute, and then you go try to run, which is like, I don't know, 15 revolutions a minute, and your brain's all weird and your body's it's a very weird adjustment from trying to go from cycling to running.
What if we invented like triathlete shoes, and they were really, really big shoes that had spring, like those big spring shoes, so you could run really fast, but you wouldn't go faster? I'm just saying, like, we might have a product. We have a product in the making here. I'm thinking,
oh my god, boom shoes.
Mike, if you ever wondered what goes on during our shows, that's pretty much it. Me saying, going, oh my god. So Chris has a question.
I like that.
Ooh, after having suffered a herniated C3 and 4, I feel anytime I do upper body training, especially pushing, chest, shoulders, etc., my upper traps are lit up. Can you shed light on this?
Yeah, I had it. I even hesitate to say this because of the joke, but I actually fractured my C4. So I know what that feels like. Not fun. And I have found a similar thing in myself and some other folks I've worked with. In pushing stuff, push-ups tend to work better. I found the bench press. Switching to decline, I found was a huge thing that helped that, because there are some translational forces that occur when you're benching. You're just pushing your head against the bench. A healthy neck or a less irritable neck won't worry about that. But I found by depressing my scapula, which has to happen when you're in a decline, because otherwise your shoulders go up to your ears. By using my lower traps, my lats more, tend to inhibit my upper traps a lot, and I felt a lot more comfortable. Dips, if your shoulders can take it, can be another option. And also sometimes you just have to retrain your motor patterns. I mean, if you've been doing the lift a certain way, and every time you pull, instead of depressing your scapula, you're elevating. If you keep repeating that motor pattern with the same load, it's probably going to just ingrain that motor pattern. So you may have to back off your training, not in frequency or volume, but in intensity, until you ingrain these new motor patterns. And I found I needed to do the same thing with my own training and many others. It doesn't necessarily mean that you're not going to be able to load again. You just may have to change your motor patterns.
Interesting. Man, how are you? Like, you are proof that physical therapy works, because you're still walking around and seem pretty mobile to me. So we have a question from YouTube. So this is our first question I think that's ever come in from YouTube. So congratulations, Christy. We're new broadcasting YouTube live. So Christy, I have a patella femoral issue caused by a bone structure issue. I'm told it's not fixable. I want to start lifting after losing 40 pounds. Where can I start while preventing locking or painful popping?
Yeah, that's a great question, and that's a really challenging issue, and I'm sorry you're dealing with that. There's a lot of theories as to why it might be happening, which I think gets to the best answer for you, Christy. But a good percentage of people that have the problem that you're talking about is that they usually have they're almost always female. It's a high propensity of female versus male, and they tend to have relative weakness or motor control problems with their lateral hip muscles. So that would be one place I'd start, is working on the glutes, working on the abductors. Some good evidence showing that correlates with improved knee symptoms. Next, ankle dorsiflexion, getting your mobility of your ankles, and dorsiflexion is another correlate that we found. And then finally, load management. I find that sometimes using your own body weight can be too much. And that's why I have people doing deloaded lunges or deloaded squats until they can accommodate their full body weight. And when I say deloading, think of the gravitron, if you can't do a pull-up, you use a gravitron to, deload your weight. Use that same concept when you're reacclimating your body to step ups or lunges, if you feel like you're ready to do that.
Perfect. Well, I think that about wraps it up. Brad, did you have anything that you wanted to touch on that we did not? Any questions? Mike's shoe size, social security number, anything that you had questions on?
How many surgeries have you had at this point?
Well, 5 of them were on a reconstruction of my big toe, which ended up in a partial amputation. That's a long story. Yeah, I got crushed from a football injury as well. 2, one on my elbow, one on my patella, and I think that's it. Yeah.
So your 10 punch card is almost full.
Yeah, my next one's free. So
that's good to know.
Yeah. Do you do your own physical therapy?
God, no. No. That is the worst thing you can do for yourself. You always outsource that. You're horribly unobjective. And no, I actually went through insurance at my own clinic because I wanted to be I had my own chart, everything. Yeah. I needed the theater of being a patient as much as the skill. So.
Yeah, I'm a firm believer in, I notice when somebody else does my programming for lifting for me versus when I do it, my progress accelerates versus me monitoring progress. Oh, yeah. Because I take the path of least resistance, which is sitting on my chair right here. So perfect, guys. Well, Mike, I cannot thank you enough for joining us today. This was a great conversation. It was an absolute blast. I learned a lot. I hope Brad actually we got Brad to say that it was out of his wheelhouse, so that made my day.
Very much out of my wheelhouse.
Not very often that we can get a question that Brad goes, it's out of my way. He does when it is, but it's not very often we get those on here. So I'm very happy that happened and I got to see it and I have it on film. So do you have anything that you wanted to, how can people get a hold of you, Mike?
I think probably the best way to find me is at my website at spectrumfit.net. I have probably about 10, 15 years plus of blogs. So if you want to have any more information on some of my writings, it's there. And there's ways to get a hold of me from there if you have any questions for me. So
and that is
spectrumfit.net.
Is that correct? Did I spell that right? It should be.
Yeah, you did. Yep.
Perfect. So spectrumfit.net. You can get a hold of Mike. I believe you're in our Facebook group too. I believe. Yep. So. If you guys see Mike around, you can say hi, contact him through his website. And if you have any questions we didn't get to, feel free to make a post in the group and our moderators will do their best. And if we can't answer it, we will tag somebody who is appropriate to help you out or point you in the right direction where you can get help. So that is all she wrote. Otherwise, Brad and I will be here just by ourselves talking about astronaut nutrition, and maybe we can talk about horse nutrition tomorrow because I'm looking at horses. I know you're a horse nutrition guy now, Brad.
Apparently, I don't know how this happened.
We got a horse box, a monthly box for my wife has a horse, and I got her a monthly subscription box, and they came with vet wrap, so I had to wear the vet wrap today.
I was going to ask if you were later or what you were doing.
No,
that's a big sweatband,
Yeah, it was just simply wear this during your live, and I don't really think I had a choice in the matter. It was you're wearing this, and okay.
Playing some tennis, is that what you're doing?
Yes, but this is it amazes me. We both said that. My wife's my wife's a nurse, and I was a paramedic. And we both said we can't believe that this is not used more in medicine, in human medicine. The vet wrap, because it doesn't stick to hair or fur, so they use it for animals all the time, but it sticks to itself, and I can't believe that. I would use this to secure.
Is it like Coban?
Yeah, but it's just not used widely enough. I don't think this is.
I love Coban.
Yeah, it's amazing. But I can tell you, I've never seen it on an ambulance. I've seen it in a couple of ERs, but never in an ambulance. But this should absolutely. I've had it on me now since 8 a.m., 9 a.m., and it's still there. But it would hold in IVs and make people easier. So
you got a new niche, the hairy guy market.
Yeah. I think that's a already existing niche in a whole other business sector that I don't want to touch.
I got enough on my plate. That's the last thing I need.
So, all right, guys. Well, Mike, thank you very much for joining us, and we will see you guys tomorrow. Take care.
Awesome. Thanks, guys.
Bye.